the right-hand side is our web portal or our self-enrollment approach. How does a person get into the web portal? So what they do is they come to our website. They take a series of validation questions. And these are 5 or 6 questions, simple questions. Has a physician ever told you you've had ALS, or have you ever been diagnosed with ALS? And then it goes on from there. And depending on how a person answers these questions, he or she either goes into the registry or they don't. For those that go into our registry, then they will have the opportunity to take our brief risk factor surveys. So let's talk about the surveys. These are the current 7 surveys that we have online right now that anyone with ALS can come in and take. And as I mentioned, by design, they have to be brief. I've heard from many of you that the questions are not long enough, or we're not asking enough questions. We hear you loud and clear. We are in the process of developing new modules, and I've got a slide that speaks of that. But just know that these modules, we are constrained by the number of modules and questions that we can ask. But I think we figured out a way how to get around that, and I'll explain that as well. But bottom line on this is these are things that are mentioned in the literature as potential, of having potential associations with ALS. And so we're really wanting to know, how people answer these questions. And it's critical that people with ALS come in and answer every single questionnaire. So regardless if you were in the military, there's a question that says, were you ever in the military, yes or no? If you weren't in the military, it's critical that you check no. I mean, that's important information for us to know as well. So very intuitive questions that you've seen on the internet with SurveyMonkey, things where you drop down radio buttons, and the feedback that we've gotten from patients is they're very intuitive. So but before I forget, we have a feedback mechanism on our website, and many of you use that feedback mechanism to let us know your thoughts, and we appreciate it. So if you've got any other questions about maybe there's some modules that we haven't thought about, or hey, this is not clear, let us know. Okay, joining the registry. Many of you out here have joined the registry, but there are a lot of patients that have not joined the registry. So it's critical that, especially for you folks in the chapters, you caregivers, that you're clear on how this process works. It's very simple. You just go to our website, www.cdc.gov/ALS. It brings you to this page here, and you click Create Account if it's your first time, and it walks you through. You'll have to read a consent form, and we have to do this for various reasons, just to make sure that you understand your rights as a patient and as an enrollee. But it's very quick. And for those who have already set up an account, you can come back and click Login and access the account that way. Risk factor surveys. I do know this, and I'll show a slide about this in a few minutes. People are coming and enrolling in the registry, and that's fantastic. But there are quite a few people that aren't necessarily taking the extra step to go and take the surveys. So I don't know if it's maybe not clear on the language that we're using, but if you can let your colleagues know, your family members, it's really vital and it's critical that people take the time to take these brief surveys. And I just wanted to show this. This is the way it looks on the screen. You click Survey 1, it takes you into a survey. 5 minutes, boom, you're done. And then you can just go down the list. And you don't necessarily have to take all 7 at one time. You can take one, come back a day or two later or at your leisure and complete the rest. All of the first 6 surveys here are one-time surveys. So in other words, once you take it once, that's it. The last survey, which is our quality of life survey, or essentially a disease progression survey, we're asking that people take it twice a year. So you take it every 6 months. On your 6-month anniversary, for lack of a better word, you'll get an auto-generated email saying, hey, it's time for you to take your quality of life survey. So we're trying to make it as easy as possible and not necessarily have patients or family members have to mark it on their calendar. Anything that we can do to give you heads up, that's what we're trying to do. Okay, this is another take-home message, and I briefly mentioned this. While it's great that people are enrolling, I think this shows, this is just the first 6 surveys here and the percent completion rates. So we know that people are enrolling, but people aren't necessarily taking that extra step and completing the surveys. So the more that we can get the word out that we really need to do this, the better. Now let me say this. The response rates here, if you look at response rates in general, these are high response rates. There are studies and surveys out there where the response rates are in the teens or 20s. So, you know, we're at least approaching 50% here. Can we do better? I think we can, but again, this is a collaborative effort. So the more people can come in and take these, the better. I wanted to put a slide up here letting people know that people are accessing the registry from every state in the U.S. And this is not to say that California is necessarily the best state out there. I just wanted people to know that we do have a great response. And I think just the sheer size of California and Texas and New York, you know, it's clear why they would probably have the most people coming in and viewing. But I couldn't show all 50 states here, but I just wanted to show that people are coming in and people are enrolling and people are looking at the website. Okay, this is probably the biggest take-home message here. We've heard this loud and clear from people. You know, dude, where's the data? You know, enough already. This is a process, okay? What people don't realize is it takes time to populate a registry. And I know, and I've heard the response from people with ALS don't have time. It's very valid. But let me just say we're moving as quickly as we can. And let me try to clarify this. So we're going to have our first data set, we hope, in the winter of 2013. And what is this data set going to consist of? What we're going to do is we're going to merge our web portal data with the national data sets. And we're going to merge it based on social security number. We'll shake out the duplicates. And in theory, that'll be our first complete data set that we can use to go in and analyze the data, to make this data available to scientists, other scientists and researchers to do their own research. But I think this graph here kind of illustrates why we're at CDC a little bit hamstrung. So you can see here, we've got data, at least for the administrative data sets, Medicare, Medicaid, and VA, going back from 2001. But, as I mentioned earlier, there's a lag time. So Medicare and Medicaid is not as current as, say, the VA data. The VA data is a little bit more real time. But just to put this into perspective, we don't have data, we don't have 2008, 2009, 2010, or 2011 data yet for Medicaid. And we expect to get 2008 and 2009 data this summer. And what we've been told is Medicare and Medicaid data, it's getting a little bit more streamlined. So our hope is that we'll get this data a little bit more quickly next year. And the same with Medicare. You know, we've got data through 2008 through 2009, but we don't have 2010 and 2011 yet. So we're essentially waiting for the data to catch up to the web portal data. Our web portal data we have ready to go. So if you think back to the last slide, we're going to merge the web portal data with the administrative data. So I just want folks to be clear that this is some of the constraints that we're working with. And if we could snap our fingers, if we could go to Medicare and Medicaid and get the data ourselves, we would do it. But we don't have that luxury, and so just know that we're moving as quickly as possible. So this is a slide that I think speaks to how important the administrative database data are. So just our preliminary analysis shows us that the algorithm is working. So you can see here, we have from 2001 to 2005 using the algorithm, we identified approximately 16,000 patients. The sensitivity and the specificity are high. One of the other ingredients that goes into the algorithm is looking at death certificate data, and NDI is just the National Death Institute data. And our statistician recently looked at NDI data, and we picked up about 9,000 more cases just running the NDI data. So we went from 16,000 true ALS cases to 25,000 ALS cases over this time period of 2001 to 2005. So this is just telling us that we feel, we're confident that this algorithm approach is working. However, we really need the web portal data in conjunction with this, because the national administrative data stuff doesn't tell us risk factor information. So this is why the portal data is very critical. Okay, just some quick things. Okay, we do a lot of different things to get our word out, and working with support groups such as the ALS Association and MDA, very critical. You guys are in the field every day. You interact with patients on a daily basis. We don't necessarily do that in Atlanta. So it's critical for us to work with you guys to get the word out. This, again, just support partners, critical. Wanted to mention this. We've got a new function on our web portal, how do PALs hear about the registry? And this speaks to what I just said. We can't do this without ALSA, without MDA, without other groups. So by and large, most people, most patients hear about the registry through you guys. So I just like to say, keep up the great work, and this is truly a collaborative effort. Registry products, we have registry products, and these products can be ordered through our website, and a lot of chapters are doing this. They're calling us up saying, hey, ship me a box of this, that, and the other. And if you're one of the chapters out there and you want this information, you can go directly to our website, click on whatever product you want, and we'll ship it to you free of charge. Again, this is the way that we get our word out, through you guys. This is just an example of, we are shipping out a lot of stuff. MDA requests a lot of stuff, ALS Association requests a lot of stuff, and clinics and mom and pop neurologists request a lot of stuff. So keep up the request, and we'll keep sending this stuff out. Continuing education module. It's very critical that we use physicians to get our word out. Physicians are on the front line. They interact with patients on a day-to-day basis. So if we can use physicians, neurologists, healthcare professionals, anyone who interacts with patients on a day-to-day basis, to get them to know about the registry, then that's another avenue that we have to pursue and are pursuing. And to that end, we've just set up a continuing education module on our web portal, and this is just an example that healthcare professionals are coming in, they are taking the modules, they are getting continuing education credit, and it's our hope that we'll update these continuing education modules to have a part 2, maybe a part 3. New registry initiatives. Let me just briefly say that we're doing quite a few things. New risk factor surveys and development. This is a laundry list of things that we have in the works right now. I won't necessarily go through it, but I want to draw your attention. You can read it, but I want to draw your attention to the last highlighted bullet here. We know that everyone with ALS has a story to tell. So for that reason, we're creating an open-ended question. And you'll have free text space to tell us anything and everything that you want. So maybe we're not asking questions. Maybe you think we're not asking the right questions and you have a theory on what led to your ALS. You'll be able to tell us this. Now, from an analysis standpoint, this is going to get a little murky for us, but you know what? We're willing to do that just because we think it's critical for people to tell us their story. Bioregistry, Lucy mentioned this. So there are several different bioregistries around the U.S. that focus specifically on ALS. We want to look at the feasibility of creating a national bioregistry that would be a component of the National ALS Registry. And we think that this is critical, and this is will help us better understand ALS. Some of the bioregistries out there right now are more regional in focus, but if we can make this truly national in scope, I think that would be very powerful. And so we're going to be we're in the feasibility process right now of trying to determine how do we fold this into the registry, and we're consulting with outside experts, some of whom are in this room. And I know I'm running over. I apologize. State and metro surveillance. Some of you out here have come up to me or our staff and said, you know, I'm a little unclear. What are you guys trying to do? There's the National ALS Registry and there's a state surveillance. You know, what's the difference? The difference is, or the purpose we're doing this, is to help us test the completeness of the National ALS Registry. Right now, there are 3 states taking part, 6 metro areas. They're collecting data on specific years. We'll take the data that they collect and compare it to the data that are in our registry and find out, are they collecting more cases than we see in our registry? If so, then we need to tighten up our methodology at ATSDR to try to find out why we aren't getting all the cases that we should see. This is just a map right now of those that are participating. Another important thing about the state and metro surveillance is we strategically pick locations because we're interested in oversampling by subpopulations. So, you know, Detroit, Atlanta, we really want to see how ALS is affecting African Americans. Same with on the West Coast, you know, trying to get various subpopulation groups. So that's another key. And again, let me just leave you with this for this slide. The State Metro Initiative is taking an active approach. They're going out and canvassing research, or they're going out and canvassing neurologists in their states and in their metro areas to find out how many of these neurologists see patients. And if they do see patients, they get a line listing of these patients. And then we'll compare that line listing with the patients that we have in our registry. So really, it helps us test the completeness of the registry. And this is just some preliminary numbers, cases reported so far just through the surveillance effort. Right now, just for these catchment areas you see up there, we're at about, I'd say, I don't know, 80%, 90%, and the case collection is still going. So we will be able to start this comparison process this summer. Last thing I want to talk about, and I'll turn it over, and this is really critical. We are opening up the registry right now. We just got approval on Friday to open up the registry for researchers and scientists to use to recruit patients for clinical trials, studies, or whatever they're interested in doing. So right now we have the largest registry of patients. Instead of waiting for our first complete data set, we thought, you know what, let's do something that's going to help researchers. So we've modified our registry, and this is how it's going to work. Researchers will come in, and if you go to our website right now, researchers can start this process now. They'll fill out an application, tell us what criteria they're looking for. Maybe they're just interested in people who have familial ALS, or maybe people who are in the military. We'll review that application, and if we approve it, we'll send that information out to PALS. We'll send the recruitment information out, the researcher contact information out, and it'll be up to the person with ALS to contact the researcher to take part in the study. So essentially, ATSDR, CDC, we're the middleman. We're not going to get involved with these studies, but we want to use the registry to pass along this information. But let me say this, at no point will we release any personal identifying information to a researcher. So let me make that clear. We take confidentiality, we take it seriously. I just talked about some of the variables. Let me end on this here, take-home messages. The registry is constantly being updated. Most of our pals hear about the registry through you guys. Our first complete data set, we're hoping end of next year. The new major initiatives that I mentioned, you can see here. Again, I think we can do a little better here with the pals who have enrolled, but they can take that next step and finish up some of these surveys. And parting words, this is a collaborative effort. We can't do it on our end without your help and everyone in this room and beyond. So with that, I really appreciate your time, and I want to make sure that the next speaker gets time, so I guess we hold off on questions until the end.
Questions at the end.
Okay. Thank you.
Thanks, Kevin, and please do keep your questions. We'll have at least 15 minutes for questions at the end. So with that, I would like to welcome Melissa, who's been integral to making the program at DoD work so well for ALS, and we'd like her to give us the insights. Thank you. Good morning. Good morning. I don't want to frighten anybody if I said I'm from the government and I'm here to help. I always tell that to our investigators. I usually get a very mixed response. But seriously, I want you to know that we are with the government. We are very much here to help, and we very much are thrilled to be partners with the ALS Association. So our office is actually called the Congressionally Directed Medical Research Programs, and if that doesn't exactly roll off your tongue, you usually have to get a good deep breath to say that. The Department of Defense works just fine. I'm not the only person that works on ALS. We have a small team. Actually, for each of our programs, we have a very small team that works on our programs. And one of my colleagues is here today, Patricia Roth. And Patricia is our science officer. She manages our grants for the program. And so she's here too, and she'll be staying. So if you have questions, you can catch her. So you might ask yourselves, why is the Department of Defense involved in ALS research? And that's a really good question. Our office, as you may know, was started in 1992 when breast cancer advocates marched on Congress and demanded money for breast cancer research. And so that year a small amount was set aside, $25 million for breast cancer research, and then the next year $250 million. Frankly, everyone thought that would be the end of it and we would all go home. Didn't quite work that way, we're glad to say, and so we've been able to accommodate other illnesses and disease processes as we've gone along. They've been added to our roster, but I just want to spend a couple of minutes telling you about who we are, because it's very important to know how we work in the context of where we come from. So who is CDMRP? We're actually part of the Department of Defense. We're part of the Department of the Army. We're part of the Army Medical Command, which takes care of all of our soldiers, wherever they might be in the world, their family members, retirees. So we're actually the largest HMO in the world. And because of that, our command, as part of the Medical Research and Materiel Command, this one here, has been charged for almost the last 70 years with finding solutions to problems in providing care. and illnesses and injuries that our service members and their families incur. So what you may not know that we have managed are to develop things like hepatitis B vaccine, yellow fever vaccine, portable ultrasound that you may see. I saw a very slick and sexy commercial not too long ago with a lady carrying a little portable ultrasound. We don't commercialize those products. We turn them over to commercial partners, but they were developed in our laboratories and research institutes, which operate around the globe. So as part of the CDMRP, we're very focused as well on solutions to problems. We're not looking long-term essentially, but we need things that can be fielded quickly to help the individuals who are involved. So that's part of our heritage, and that's where we come from. So some of the hallmarks of the CDMRP you may know or not, that the funds for these programs, the ALS program and all of our other programs, are not part of the President's budget that's delivered to Congress every year. We're not in the core budget. So they're added at the behest of individuals like yourselves, and I'm not encouraging lobbying because I have to do this. But seriously, that's where they come from. They're all programmatic additions. There are no earmarks anymore. They're programmatic additions. So we never know then from year to year if there will be additional funds the following year. What we know is what we have this year, and what we know is that we have to do the best that we can to invest it wisely on everyone's behalf. So the vision is adapted yearly, and we change our funding mechanisms as needed to fit the niches and the needs that are out there that we see every year. It's a bit like living with the phoenix, and we rise from the ashes every year, so to speak. So our business manager sends us an email and says, hooray, Congress passed the bill, we all have jobs. So, which is not what we're in business about, but we are in business to keep our programs going as long as they're needed. And when they're not needed, that would be a great day. We'll be glad to walk away from them. Consumer advocates like yourselves are involved throughout the process. So we have advocates who sit on our peer review panels along with scientists and clinicians, and they vote on the proposals just as those scientists and clinicians do. We tell them that they don't have a degree necessarily, but they have a degree in survivorship. That's what you have. So we do ask for your participation. We've been very humbled and proud to have those folks join us on peer review every year. We try to fund innovative research. We try not to duplicate what our colleagues in the government and outside of the government, such as what the ALS Association is funding. There wouldn't be any need for us if we were just doing what everybody else was doing, just doing more of the same of it. So we do a two-tiered review. A lot of institutions use this now, but ours was recommended to us by the National Academies of Science, Institute of Medicine, and then they came back a few years later and evaluated the process and were pleased with what they saw. So I'll talk about that in a second. So we are all about partnerships. You've heard that mentioned already a couple of times this morning. It starts very much with you all, with our advocates. I can't get that on this, that won't show on the screen. With advocates. And again, we ask for our participation of advocates at all levels. Ellen isn't here today, is she?
Yes, she is.
Yes, Ellen?
Front somewhere.
Ellen? Ms. Ellen Phillips is one of our integration panel members, as is Dr. Bruin. So we do have representation. We have another gentleman who's from a different foundation on our panel as well, and peer review. So we do have advocates who participate at all levels. That's very important. And we know that we need to be responsive to your needs in serving you as part of the program. And then Congress, of course, adds the funds to the defense bill every year, hopefully. They didn't in 2008, but that's okay. They came back in 2009, so we're happy. And they give us the opportunity to leverage those dollars. We're proud to manage those, and we try to be very good stewards of all of those dollars that come into our coffers. We use them only for the disease as specified by Congress, so we don't use our ALS dollars to fund research in any other area but ALS. And if you want, you can follow our budgets every year to the penny. We account for it, all of it, and post that as part of our annual report that's on our website if you want to see that. You can easily follow where the funds go. And I know you could probably agree with me, that's not always something that you can do when funds go into government coffers. So All right, for research, the researchers, we rely on them exclusively to adapt and respond to the needs that we put out there. Sometimes we have to pull the scientific community kicking and screaming to respond to what we're asking them to do. Sometimes we're asking them to do something that's a little bit different and out of their realm of experience, and that's okay. I get my watch to cooperate. So this is what our funding lineup looks like for 2012, fiscal year 2012, since we operate on a fiscal year. And ALS is the first there. Of course, I think it's first anyway, always. But other programs, everyone took a rescission in 2012 of about 20%. So even if you have a lot of money in a program, 20% hurts, but when you have very small dollars, 20% is very difficult. However, we were happy to survive 2012. It was not a good fiscal year. I'm sure you remember the battles that went on. So this is our program cycle. I don't want to spend too much time on it, but if you start to the upper left, of course, it starts with the congressional appropriations, and then we receive the funds. If it's a new program, for example, last year, Duchenne's muscular dystrophy was a new program for us. We have a stakeholders meeting where we invite all of the groups from all the different perspectives to come together and to help us flesh out a program. So we do that once. But every year we do vision setting, what we call it, looking at the horizon, looking at the landscape, and seeing what the needs are for that particular year. Again, knowing only that we have those funds to work with. Then we craft award mechanisms and release program announcements to attract the investigators to submit, in this case, pre-applications. We've gone to pre-applications, I'll show you in a minute, because our receipts have been so robust. So we ask them to briefly tell us what they want to do, and then our integration panel, I'll tell you more about them in a minute, screens those so that the investigators don't waste their time on a topic that is not of interest to us, or that we may have already funded, to fill out a full application, because sometimes these applications get very large. Then we invite those who are going to submit full applications. They submit their proposals to us. They are peer-reviewed. That's the first review that determines scientific merit. And then they are, at the second level, programmatically reviewed. It's a different process. Our integration panel is central, as you see there. They are a group of scientists, clinicians, and advocates. So Dr. Bruin is on it, Ms. Phillips is on it. There are a number of notable scientists and clinicians on that group. They help us every year with those functions. They help us set the vision. They help us select those pre-applications that are most promising. And then they perform the second level review where they recommend to us which of those applications should be funded. Those go on to our commanding general for approval. Then the award negotiations begin with the investigators, and that's where Patricia comes in and makes sure that every dollar that's sunk into that proposal really needs to be. And yes, how many animals do you need? So we do all of those things. And then grants management, and then we monitor those awards for their lifetime and beyond. And what you should really see is an arrow that goes from that grants management box back to vision setting, so that what we do and what we find as our awards progress feeds back into the vision that's set then every year. So it really is a partnership, again, between our peer review panels on the left and our integration panel on the right. They perform the 2 tiers of review for us. Each program has their own peer reviews. They have their own program cycle that I showed you. Each of them, it makes our director crazy because he's going in 16 different directions, but that's okay. And we get different things out of each level of review. The 2 levels do not communicate, so that there is no crosstalk between them. We don't have standing panels for peer review. Our panels are reconstituted every single year so that they don't take on a personality, they don't take on an agenda of their own. We get critiques and scores, summary statements from them for each of the applications that are reviewed. And then our integration panel at the second level, at that programmatic level, they compare and contrast the different applications across disciplines or across areas of focus to find those that most meet our programmatic intent, are most relevant, in some cases the most innovative, and have the most impact. So just because something has a wonderful scientific score coming out of peer review is not necessarily an indication that it will be recommended for funding. Because if we already have a proposal like that in the portfolio, with our limited dollars, it wouldn't make sense to fund another one, even if it's really good. So our portfolio is very diverse, and that's why we do it that way. And out of this group comes our funding recommendations. So let's talk about the ALS program, because that's what we're really all here about. So this is our vision and mission, and hopefully that vision statement resonates with you all, because like you, we can envision a world without ALS. We'd very much like to not be doing this job and work ourselves out of a job and find another disease to work on. That would be wonderful. And so our mission, as we've carved it, is to develop preclinical therapies and treatments for ALS, because we all know that they don't exist. So it's interesting, but we have found that we don't duplicate what our colleagues are doing. So you heard from Lucy what the ALS Association is doing. We're not doing that kind of work. Our colleagues at NINDS, their portfolio is very different from ours. Of course, their budget is about $45 million this year, so they can afford to do things like initial clinical trials or other things that we can't afford to do with $6.4 million. So this is what our funding history has looked like, and starting to the left, FY fiscal year, so if I say FY, I'm sure you know what I mean. Fiscal year 2007 to 11, we're understanding that fiscal year 2008, we did not receive any funds. So 4 years, $25.5 million, a very robust response from the scientific community, 449 applications submitted in that time period in just 4 years. 14 awards plus 5 that we have in negotiation from last year, from 2011. So about a 4% funding rate, which isn't real encouraging for the investigators, but we have to do the best that we can with what we have. And so we're very appreciative of the fact that they come to us with wonderful ideas. Last year, the budget was, in fiscal year 11, was $8 million. And so we were able to make 5 awards. This year, as you see, the budget is $6.4 million, so we're envisioning 3 awards. So every dollar counts, and we'll make it work. So this is our portfolio by mechanism. We have basically 2 awards that we've been offering. We started with 1 award mechanism in 2007 and added the second one, the one on the left, the Therapeutic Idea Award, in 2010. And so this is the way our big portfolio of 14 awards, but that's all right. They're wonderful awards. Now, this is by research topic, and again, you'll see that they're all focused on the development of drugs or treatments. They don't correspond to the previous slide that also broke out at 10 and 4, so that doesn't cross over. But these are wonderful projects. If you look in your folder that you have, which is a terrific piece of work, by the way, that was really a lot of work that went into putting that folder, that binder together that you all have. Back in one of the tabs, you'll find our booklet for our ALS program. It's yours in the book, in the tabbed folder in the 3-ring binder is going to be in black and white. But there are these also, I think, going to be made available. But I wanted to let you know a couple of our awards that we've highlighted in here for you to see, just so you can get an idea of how diverse the portfolio is. So we're looking at a number of pathways to find treatments for ALS. And as Lucy said, that's very important. You have to look in different places and explore different pathways. So we're trying very hard to do that. 5 minutes, okay. All right, in the interest of time, we'll move on. These are our 2011 awards. The titles of the awards are actually in the booklet. I can't tell you much more about these awards because they haven't been negotiated, so they're still considered sensitive. We were also able to partially fund one of our first alternate with money that we had left over from our management costs, so we try to operate pretty close to the bone. This is our program cycle, and you've seen it in a different representation before, starting with the congressional appropriation, but I just wanted to give you an idea of what our timeline. We had our vision setting in February. We released program announcements in March, and then we're actually Wednesday screening those pre-applications that came in, and then the 24th of July, their full applications will be due. And we'll get those, the second level of review done before Christmas. That's our goal. And so the award negotiations can begin right after the holidays. So we're trying to compress this time schedule every year so that it gets shorter and shorter. The money doesn't do any of us any good as long as it's sitting in our hands or in a bank account somewhere until it gets into the hands of the investigator. So we try very hard to move that along. This is what our budget looks like for this year, $6.4 million. As I said, withholds come from our higher command MRMC. That's to keep the lights on and to keep the folks in our contracting office working and so forth. It's only $290,000. You can imagine it doesn't go very far, but that's all they take. And then our management costs, and we of these management costs, last year we received $150,000 back at the end of the year because we operated so tightly on our budget. So that was really very helpful. So we hope to have more than 5.62 available, but we don't know that for sure. That's what it looks like we'll have. So this is our investment strategy for this year. 2 award mechanisms. The IDEA Award is a much younger award. Earlier in the pipeline, as Lucy described it, the Therapeutic Development Award, obviously you can see that as a big award, $1.5 million. And these don't include what are called indirect costs. So the institutions, normally academic institutions, negotiate indirect costs with Health and Human Services, and those can average anywhere from 50 to 110%. So those costs get added on to the award. So a $1.5 million Therapeutic Development Award can end up costing $3 million. Okay, so the Therapeutic Development Award, as I said, is it's our first award that we use. We've been very successful with it. We have 10 awards in our portfolio that are Therapeutic Development Awards. It is focused solely on preclinical assessment, so no clinical trials are allowed. We can't afford that. They have to include preliminary data. The investigators have to show us that this would reap a substantial benefit for for you all and those who have ALS. And $1.5 million. Now, these are the areas of emphasis for that particular award, so it covers a large segment of that pipeline that Lucy talked about. So that can begin with screening and developing new screens to identify targets. It can include the refinement or validation of models, because we don't have a lot of valid model systems that correlate well to the human situation. We know that. And developing pharmacological agents, identifying them, and being able to manufacture them, which is a problem. Sometimes you can identify them, but you can't get them into a packaging that actually is tolerable or that someone could use or take. And then they develop them up to the IND stage. And so I'm sure you're all familiar with what that means, but it's a big submission to the FDA that then allows them to start clinical trials, but only after this award is over. The IDEA Award, by contrast, is to promote very new ideas. They also have to be focused on therapeutics, however. Up to 2 years. Preliminary data is not required. So this is, what is your good idea that's in a new avenue that can challenge some existing ideas about how we move forward in ALS. So these are high risk, potentially high gain types of research, and we hope that they will make critical advances. Now, innovation is always a difficult thing. I don't know if you're like me, but my definition of innovation is I know it when I see it. Okay, well, that's a good thing, but that's really hard to describe. And so we've had to describe it for our investigators. So this is the definition that we use with them. It may be innovative if it introduces a new paradigm, challenges existing paradigms, new concepts or agents, or other unique qualities. So trying out a particular cell line that's been tried before in another disease and bringing it to ALS is not innovative. That's just one more thing. The next step. So we're not interested in the next step. We want something that's going to leapfrog our research and then impact, again, something that's going to be significant. There has to be some demonstrable benefits from this. This is the group that's on the integration panel that I spoke to you about that conducts our vision setting, our pre-application screening, and our programmatic level review. I think you probably recognize some of these names. So we do try to work collaboratively. There you see the Department of Veterans Affairs, NINDS, NIA, the ALS Association, of course. We have members, a microbiologist with a genetics interest from the Air Force, and our gentleman from the ALS Hope Foundation. So they do a yeoman's job for us for very little return, but we hope think they enjoy it. So we envision what you envision, which is a world without ALS. We'd like to see that happen. We'd like to find a treatment for ALS or a cure, and that way we can all move on. But we want to work with you, and I'm thrilled to be here today, and thank you so much for your attention.
So we have just a little under 15 minutes for questions for both of the speakers this morning. So welcome any question and any thoughts that come to mind. And I do think we have some floor microphones, right? It's quite important to get those so we can hear the questions clearly. Where are the floor microphones? I think it's important to... Can you repeat the question?
So, good question. When will we implement? Yeah, I'm going to repeat it. So, when will we implement the open-ended questions, and will existing PALs be able to go back and take these new surveys? And the answer is the surveys are rolled out in a phased approach. We anticipate this particular one will come out at the end of 2012, if not sooner. But again, that's based on government time, which can be, that can mean a lot of different things. But our goal is to have it out by the end of this year. Another module I didn't mention is a clinical module. We work with various groups, ALSRG, and physicians, and they want to know specific clinical information. So we're putting the clinical module and the open-ended questions kind of at the top of the pile because we want these questions to go out. And yes, people who are already enrolled will get a notification saying there's new modules available. Please go to your account and log in, and you'll be able to take the modules, the new modules.
If you could stand up or raise a hand so we can see where you are with the question. Oh, here, microphone here, please. There are some mics on the floor, and they're coming rapidly to you.
Good morning. My name is Mary Johnson, and familial ALS has really run rampant in our family. To date, we've lost 9 family members. As of March 13th, we lost my 34-year-old niece. So for me, my question is, how can I put my family members' information in that data pool registry? Because it's important for you to know about those 9 people in my family to help draw a correlation for us in the future, for those of us who may have the gene and may get it at any time.
So very good question. Familial ALS is something that we really are interested in, and I think that speaks volumes there. So the way the registry is set up is we want folks who are living with ALS now to come in and enroll. We get asked this question a lot, why can't I put in a deceased relative? And it's not that we don't want that information. As a registry, typically you start at one point in time and move forward. So if we try to go back and capture information from someone from 1985 or 1990, it puts gaps in our registry, and it can create bias and incomplete data. Now I realize that that's not a satisfactory answer, but for any registry, you typically start at one point in time and move forward. But maybe this open-ended question, if someone is, in your family has ALS and they've enrolled, that would be a great place to put that information. You don't necessarily have to list all their names, but you can mention, what you just said, and that's helpful information to know. Maybe you're not the only person out there that's like that, and no, you're not. So that's the way this model works right now, is one point in time and we move forward. But we do have a familial module, and we are capturing this information.
I see a question. Okay. Behind, there are 2 questions behind. If you can just get mics there.
I live in a town called Pottsville, Pennsylvania. It's in the Coal region in northeast Pennsylvania. And where I live, in about a 25-mile radius, there's about 8 people who have this disease. And for such a small area, to me, that seems like a lot of people. If the assertion is that there's only 30,000 nationwide. I would just like to make that statement.
So let me just respond to that. One of the good things about the registry is it will provide us baseline data so that we can look at certain catchment areas, try to define, is there what we consider a cluster? If so, maybe we can go back and look at some of these people, hopefully who have enrolled, to see if there are common threads. Maybe they have the same occupation or usual occupation. Maybe they were in the military. There's a lot of things this registry can be useful for. So I don't know if that necessarily answers your question, but we do hear that quite a bit, that people say that there's clusters of cases near where they live.
I see a question there at the back with the
My
mic.
name is Bill Soto. I live in Cookeville, Tennessee. I was diagnosed with ALS last year, April 14th. And, yeah, I know the accent. I'm from Cookeville. I'm from New York. That's all right. Anyway, living in small towns, you mentioned something that intrigued me about getting neurologists more involved in the registry. Why not get patients like me? Is it appropriate for me to approach the neurologists who, quite frankly, in my area, I'm not sure they know how to spell ALS, but to get them more involved in the registry and be proactive in that registry? And is there a module for neurologists for that registry?
So a couple things. Like I said, this is a collaborative effort. We're a very small group at CDC. You guys are out in the field. You interact with neurologists. You interact with chapters. The more we can do to spread the news that the registry is here and it's in existence, the better. This is one of the reasons why we created that continuing education module. It's kind of the dangling carrot to get neurologists and other healthcare professionals to come in and take the module or take the continuing education component so that they become familiar with the registry. But I agree, and it gets back to our promotional stuff. The more we can work with ALSA, the more we can work with MDA, specifically with their funded clinics to push this information out the door, the better. Some physicians have told me, hey, we've already integrated the registry in our checklist of things that we give to patients who are newly diagnosed. I think that's great. That's the way to educate people right from the get-go. But again, it's something that's done on a case-by-case basis, and if more people could do things like what you're doing and being proactive, the better it benefits all of us. Thank you.
One here and one in the front and one at the back there. Go ahead. You have the mic. You go ahead first.
Okay, 2 short questions. Will the slides from these talks and the rest of the day be available on the ALS Association website?
I can certainly make mine available and we can check with the others, but that's a very good idea and I'm sure that
Yeah.
our team can coordinate that.
Please do. And if you can throw in, Kevin, on yours, the links to anything that you want us to complete, I'd suggest you do that.
Okay.
A delicate question for Melissa. As a trained person in technology, integrated circuits, and so on, I know of military programs that will not work. We just know it in advance. We've seen it more than once. If we were to suggest that the criteria is saving lives, and a more efficient way to do that would be to reallocate funds within the Defense Department, you saying that would be probably poison to members of Congress. Us saying that might not. But we could well benefit from not just the slides, that slide with the budgets, for instance, but from additional questions that later on maybe we could ask you? Good.
There were some in the back. Yes. Do you have a mic? If you could, and yes, please with the mic.
Well, in sort of a relationship to what that gentleman just said, how much cooperation are you guys getting with the DoD and Department of Defense in their military appropriations for ALS, since they probably have a deeper budget than yours? And are you guys, your research projects, are they cooperative with where the military is going, or are you guys going in two different directions?
Well, I'd like to think that what we're doing is we're complementing one another. The registry, this is the only congressionally mandated registry out there. So what we're doing at CDC ATSDR, the DoD is not doing this. But they can feed off of what we're doing. They can use our registry to recruit people for clinical trials. And one of the things I didn't mention is we want to make the registry available to even pharmaceutical companies. Anyone that has an interest in using the registry for purposes of advancing the science, we're all for doing that. So I think bottom line is we're complementing each other, and we're definitely not duplicating efforts.
And I'll just add that I think what Lucy talked to you about earlier of what the ALSA is funding in terms of research, attracting new investigators and doing other things is not what we're doing at the DoD. We're exclusively focused on the development, the preclinical development of therapies for ALS. And NINDS, the National Institute on Neurological Disease and Stroke, their portfolio is very different from ours. They're not looking at the preclinical development of therapies. They're looking at basic questions about ALS, the pathobiology of ALS, and developing other things. We're not doing the same things. So that's why the last slide I showed to you, at least for our integration panel, the folks who are on there, we bring them on for what the perspective they can provide to us of what is happening in their organizations so that we don't fund what they're funding. It wouldn't make any logical sense except or obviously replication of studies, but we're not there yet. But we're very careful not to duplicate, and that's what Kevin said. It's true.
That's part of my point. My point is you can think something is important on our side here, but you can get the military to do your research and spend their money and not your money, so to speak. I think it would be good to duplicate efforts.
So, well, we do talk with our colleagues at Fort Detrick who are working on other related types of diseases, but please understand that their focus is on saving lives on the battlefield. That's what they primarily do, or other diseases that our soldier population and their beneficiaries incur. So their focus is really different. They're looking at solving wound bleeding and other things like that. So they don't have pockets with this kind of money to do this kind of work. That's why we were asked to do it. There is no budget, at least in our command, where 90% or if not more of the research in the medical department, the Army, goes on. There aren't research dollars beyond that they are not researching ALS. It's not a problem for soldiers on the battlefield. So, right.
So I'm going to take it from there because I know you're all going to need a break before the next session. I will just add that it's very evident that 6.4 million, although it's fantastic to have it, is not sufficient for drug discovery. And so we are all partners in this to make sure we try and mobilize more funds. That's why the point was made that the industry is more motivated. We are engaged in small pilot studies to de-risk. The NINDS and NIH have translational programs that we do want to tap in. I think the important point that Melissa made is that we make sure that we are using what we have in a very productive and careful way, and that there are certain instances where we, even in our programs, duplicate funding. We'll hear that today, chromosome 9, there were 3 groups battling independently with different technologies, and 1 or 2 of them came out and others are working on different approaches. So it's critical. I'm sorry to cut the questions short. I know this, one more question from the lady here who's been anxiously waiting, but I know that both Melissa and Kevin are around, so please do come and ask your questions. If they are not answered in the time you have, then email our organization. We will be happy to address them. So the final question before I close.
Yes, I'm Hollister Lindley. I was diagnosed in September of last year. The question's for Kevin. I've lived all over this country. 0 to 3 in Chicago, 3 to 23 in Honolulu, 23 Erie, all over. Does the CDC database capture the fact that I have lived 8 years in Erie and 2 years in Philadelphia and 5 years in Boston, and capture that sort of data? I heard the gentleman who said, yes, you heard my New York accent, I didn't grow up here.
Right.
Do you capture
Yes,
that?
great question. In the new modules that are coming out, we have a detailed residential history module, and I think this is this can be useful in a number of different ways. Cyanobacteria is something that scientists have hypothesized is, maybe causing ALS. We can take this residential module, detailed residential history, kind of map it out in areas of where there are algae blooms and do creative things like that to see if, is there some kind of association. But bottom line, yeah, we'll be capturing it.
So on that note, I really want to thank you all for your attention, thank the 2 panelists for tremendous presentations. And please join all the other sessions. You'll learn a lot more about the current research activities. Thank you.